Hi, how are you? And welcome to the 4th International Dental Symposium in Kampala, Uganda 2021. My name is Carolina Vera. I'm a clinical assistant professor of the University of North Carolina, Chapel Hill, Department of Comprehensive Oral Health. And today I have the honor to participate with Build Your Smile Dental Foundation to talk to you about sleep apnea and dentistry. Let's start it. I'm going to talk briefly about what is sleep. Well, sleep is a physical and mental resting state in which persons become relatively inactive and unaware of their environment. It's a reversible behavioral state where usually is a very essential part of life of all mammals, and is a very, very complex amalgam of a physiological and behavioral processes that honestly is very complicated to explain. It's right now, for the purposes of this talk, it is, it has been a very, very detailed classification of every single stage of sleep. However, the only thing that you need to remember is that the sleep is characterized for two distinct stages, that is non-sleep, non-REM sleep, and REM sleep. And those cycles last around 90 to 110 minutes each. And a normal sleep night, usually they have 4 or 5 of those cycles. Is sleep important? Of course. Sleep is extremely important, because if you have a good sleep, you have energy, you have a good metabolism, you have a very good hormonal balance, your tissues get repaired very nicely, the growth and development in children is a lot better, learning and memory is improved, the mood is better, and usually sleep well prepares us for the next day to have more alertness and have better performance in whatever we do. But what happens when this homeostasis during the sleep is not possible? What happened? Okay, well, sleep has been just recently become part of the medical field. And right now, although sleep is starting being studied, they have an international classification of all these sleep disorders that exist. Right now, in this conversation, we're going to be focused mostly in sleep-related breathing disorders, which are the second most common sleep disorder, and because the first one is insomnia. So insomnia and sleep-related breathing disorders are the most common ones among the population. But in general, so let's think about if these problems are very prevalent in the population, what happened with that people? Well, sadly, and accordingly with the National Commission of Sleep Disorders, the 95% of those patients which are suffering and currently being tortured by these sleep disorders remain undiagnosed, and mostly because the healthcare providers have not had the opportunity to learn about the sleep disorders, and they have no idea how to treat them on what is necessary to be referred to be treated. So, and unfortunately, in the kind of a regular day life routine, we just don't think about that people may having a sleep, a sleep problem or is facing a sleep disorder. We know that, whenever we talk about the sleep deprivation, we know that not sleep is very common. Sometimes when you're studying, when you're working, when you're doing something, sometimes because you're watching TV, who knows? But 32% of the Americans, they sleep less than 6 hours per night. And a lot of these sleep deprivation problems, they just became more complicated, because I will say that 22% of these adults, they had accidents while they are driving and they are falling asleep. And then, they may think about because they were tired, or they would just blame something else, and they don't have an idea they were having a health problem. Another thing that I have realized lately concerning these sleep disorders is that sometimes even the cartoons or in the TV or in books or whatever, usually when somebody is sleeping is snoring. And guess what? Snoring is not normal. Snoring, although we see that as such something that is extremely common, is not normal. 87 million Americans snore, and 45 million of them, they snore every single night. So, we know that snoring is more prevalent in men than in women. And also we know that that if you snore, most likely is because you are having a breathing disorder and you are unaware of it. And, if you think about that in your family members or in your friends, I think you can hear about somebody that is being treated for asthma, for cancer, for diabetes. But have you heard a lot of people that is being treated for obstructive sleep apnea? I think people is being more aware about this, but still, I think it's not something that you hear very often. Part of this, the purpose of this quick talk is that we are starting thinking a little bit more out of the box and thinking about that this is a serious problem. Obstructive sleep apnea is something that is extremely prevalent in our patients, and we starting being more aware about it. Because, unfortunately, these unrecognized patients are just deambulating around and they're among us, and what they are causing is just, probably accidents in work, and causing, a social problem. But in general, what is the prevalence of obstructive sleep apnea in the United States? Well, now, after all this, we know that the obstructive sleep apnea is more common in males than in females. As you are getting older, it gets worse. So also, if you increase weight, it's going to be even more severe. A lot of the times as a dentist, we don't, we need to learn to see a little bit more bejoined teeth and what happened and how does a normal airway should look like and what is the variability and when the patient will need a little bit more help from us. This is how a normal airway looks like. And you can see what is the space of the airway and what is, there is a sufficient amount of space for the air to passing by without having any problems. And, the patients are able to breathe and doesn't matter the position and all these soft tissues and the palate and uvula and tongue are not having any problems and are not blocking absolutely the airway, despite that the patient is relaxed when they are asleep. And you can see better in this diagram how or what is the space of the normal airway, and the air is just passing by without any friction because there is no collapsibility in any of those structures. But sometimes, as soon as the patients open the mouth, we as dentists have the responsibility to start checking more than the caries or the gingival tissue, right? And starting checking all these anatomical characteristics of every patient. What happened? And right now, as I said, we have studied a little bit more about the sleep medicine, and they have developed different scales that they can help us to diagnose better these patients. And sometimes we have anatomical findings like enlarged tonsils, or very long soft palate and uvula that are blocking that airway, or a very large tongue that sometimes you can clearly see it in the side part of the tongue because the teeth get marked and it looks like a scallop tongue. And, sometimes the linea alba because the patient is bruxing, because it has been seen that bruxism gets increased when the patients are having, respiratory problems while they are asleep. But then You know, if something is wrong and that normal airway gets collapsed, this is when the snoring happens. And sometimes, you know, because the airway is too small or becoming a little bit more narrow, though, because the you know the flow, the airflow is not the same, and that area has been a little bit more restrictive, then exists the vibration, and is when the snoring happens. So you can see a little bit better how these tissues have been closing a little bit more the passage of the air, and is when the patient is starting having problems breathing, especially if he's sleeping in a different position. Look at these structures. You know, you can see here, you know, a very, very large uvula, almost, you know, no way to see where the air is going to pass by, you know, enlarged tonsils and everything. So when the patient is open the mouth, you immediately need to be suspicious about that this patient must be struggling when they sleep. And that is correct. So it is a completely blockage sometimes of the airway, and is causing the airflow to stop. And is that blockage of the airway causing the airflow to stop is what we call apneas. And you can see that clearly here in this diagram. But what are the clinical symptoms of a person which is suffering of obstructive sleep apnea? Well, as I mentioned before, this patient is going to be snoring, and snoring usually pausing, intermittent and pausing snoring. Is going to be very, very tired during the day, is going to be very sleepy. And sometimes they can tell you that, you know, they feel like they have oppression in their chest when they are asleep, or, you know, or sometimes very light and unrefreshed sleep. A lot of the times, the bed partners of the patients are able to help us to diagnose this better and say, you know, because sometimes the patients are so tired that they're unaware that this is going on, right? But if you talk to the person that is the bed partner of the patient, is able to validate all this information, and is extremely helpful. So, because it's not just what happened at night, right? But all the other characteristics that this patient is going to have. So most likely this patient is going to have poor memory, clouded intellect, is going to be very irritable, is going to have morning headaches, you know, symptoms of gastroesophageal reflux, decreased sex drive, and personality changes because it's not resting enough. And it's when sometimes different approaches have to be taken. And sometimes, you know, us as a dentist, we can help them with, you know, some appliances, or coaching the patients to have different modifications in their behavior and different risk factors, to have what we call hygiene while they are sleeping, to, you know, to stop smoking, to change the position when they are asleep, to take different pharmacological agents, you know, like melatonin, to help them to sleep better, or sometimes, you know, to have or use a machine to help them to open the airway a little bit more faster. However, you know, sometimes these treatments are not very successful, and depends on the severity of the case. Sometimes surgical management is necessary. Because ultimately, what happens when there is a sleep apnea? So if the patient is asleep, this is a cycle. So the patient is asleep, the muscles are starting to relax, the tongue is very heavy and is starting to be collapsing, blocking the airway, and then there is a stop of the flow of the air, and is when the apnea occurs, right? Immediately after, there is a decompensation between the oxygen and the carbon dioxide. That situation is going to increase the ventilatory effort of the patient, which is instantly going to send a message to the brain, creating an arousal. So the patient is going to wake up and is going to notice that, you know, that the air is not present anymore in the airway. It's going to start in hyperventilated, and again, is going to fall asleep, and the cycle is starting again. So can you imagine how difficult and how you know, wearing down situation is happening every night? And, you know, Unfortunately, patients that they are not treated with obstructive sleep apnea, yeah, I mean, they will have not just unrefreshing sleep and they're going to feel tired and lost of memory. No, no, no. Everything is just going to be worse and worse in the body. And ultimately, our major concern with this sleep apnea is the sleep fragmentation, because the sleep fragmentation is going to cause, as I said, not just excessive daytime sleepiness, but cardiovascular complications that ultimately both may just increase the morbidity and mortality of the patients that are suffering sleep apnea. And well, as we discussed, this became a social problem for most of the patients, causing a lot of depression. So it's just not the physical, tiredness, but the social environment that they get involved, right? Because they have problems at work because of the poor performance. They have a decreased quality of life, problems with the family, increased chance of having an accident, or increased, possibilities to have or to get help because they get depressed very easily. And again, these are the very common comorbidities that the patient is starting developing once is not being treated for sleep apnea, which is cardiac arrhythmias, myocardial ischemia, cerebrovascular disease, pulmonary hypertension, and systemic hypertension. So what I try to do with this quick conversation with you is to help you to think about out of the box, right? To think about that if you have a patient coming into your chair and you see that the patient is a little bit obese, is, a little bit, old, getting old, is a male, and have, a not very open airway in the back, that has a very bad family history of diabetes or stroke, or somebody in his family, he loves alcohol and is smoking, well, you know that there is a person that is in a high risk to have a problem. And then again, it's very important to extend a little bit more our medical history, our diagnosis of the initial diagnosis of the patient, and checking the BMI. If that patient has a very big neck, and if the patient has a previous history of congestive heart failure, atrial fibrillation, diabetes, stroke, pulmonary hypertension, I don't know, it's very, very important to also check that the patient have a good monitoring of all these diseases. So once we have identified that person, it is extremely important to have a definitive diagnosis. And for that, there are two methods that are going to help us to determine what is the degree of the problem of the patient. So our gold standard and the very the best methods to diagnose obstructive sleep apnea problem is the polysomnography. The polysomnography is made in the lab by a technician, and what they do is they hook a lot of they put a lot of electrodes to the patient's body, and definitely is going to help us to have a very detailed recording of everything that happened at night. What happened with that patient, what are the stages of sleep, what happened in non-REM, what happened in REM, how many cycles, and every single disturbances that could happen during the sleep. And of course, these kind of studies are not cheap, and a lot of patients cannot afford them. However, right now, technology is improving, and home sleep studies are better and better per day. And right now, we can use even a simple oximeter, or again, we can start in, we can use these home sleep studies, at least just as an initial assessment of this patient. It's not necessary sometimes if you are suspicious that one of your patients is having one of these problems, you can start contacting them and have a quick sleep study. And if the sleep study is positive, then the patient needs to be referred to have medical intervention. because what we need to make sure is that this patient is taken care of in many other different ways. It's important that the patient not just have a change in their behavior, in their habits. It is important that the patient is being treated, trying to make sure that the patient has a very good nasal breathing, that is able to use other pharmacological agent, or sometimes that is necessary to use a combination therapy with all of them to improve the quality of life. Our also gold standard to treat patients with severe obstructive sleep apnea, it is the CPAP, is pressure that is injected through the nose using a nasal mask. And what this air does is just preventing the collapsibility of the airway, keeping it open and helping the patient to breathe better. CPAP right now, again, they are improving every year. And right now they are more affordable, I will say. There are some of them very easy to handle because they're automatic, and they basically, according with the resistance that the patient is having when they are breathing, they are automatic and they're very simple in maintenance. Again, what happened with the patients, they don't respond to any of those quick treatments that we are doing. Well, sometimes we have to go a little bit more aggressive with the therapy. And, you know, sometimes maxillomandibular surgery is necessary. Sometimes the palatopharyngeal plasty with laser or tracheostomy is required. And sometimes low temperature with radio frequency, it's very helpful to treat these enlarged tissues and create a little bit of plasty, so to open the airway. As dentists, are able to help the patients with the sleep apnea, creating different appliances that they are very, very, very big in number and then designs. And this position of anatomical or reposition anatomical structure is nothing new. It has been happening for many years, and they have been using helmets, chin straps, mandibular surgical advancement of the mandible, and different methods, you know, just to preserve or to change the anatomical structures to help the airway to maintain open, because ultimately is what these appliances do. They prevent that the oropharyngeal tissues and the tongue collapsing the airway. And then I will put a little bit of example of what happened with these oral appliances. Mostly, these appliances are divided in three, which is the mandibular repositional devices. The only thing that they do is they push the mandible forward, and they try to maintain that in that position. Another one, the tongue reposition, there's repositioning the tongue itself out of the mouth. And another one that can be used in combination with the CPAP. This is a great example of the tongue retainer. Sometimes for a mandibular device, it's very important to have all the teeth, to have any of the teeth moving, to have a very good function of the TMJ, to have, you know, certain characteristics. However, when that is not possible and you have insufficient amount of number of teeth, when you have a problems in your TMJ, when your tongue is extremely big, or sometimes when the tongue is very, very big and fat, because remember, when the patients are overweight, the fat stays in the tongue. And sometimes when the patients are laying down, you know, the tongue is just very heavy. And, you know, these appliances, which is the tongue retaining devices, are very helpful for that. So this is an example of the device. Very well tolerated for the patients because, you know, it's basically reversible. And then you have these mandibular repositioners that these appliances have been extremely effective in mild, moderate, and severe obstructive sleep apnea. However, they have shown to have better performance in mild and moderate sleep apnea. These mandibular positional devices can be adjustable and non-adjustable. This is an example of the one that cannot be adjusted. You can see here, this one is mostly maybe for patients who cannot breathe through their nose, And then you have this passage created between the two arches when the patient, if he's still breathing through the nose, is able to have this space and helps him to have, an extra breathing. These are the mandibular repositional devices that they're using different screws and titanium appliances to maintain the position of the mandible. This is the EMA appliance that is very common, very, very affordable for the patient. And sometimes they use the specific elastics to know how much advancement for 8 and 11 millimeters are going to have for that. This is another one, very common, very good for patients with bruxism, which is the Herbst appliance. Is a little bit more resistant and gives you a little bit more anterior, posterior, and lateral movement freedom. It's very well tolerated by patients with bruxism. Again, another example, this has Velcro on it. I don't know how comfortable it is. Well, it's a choice for some of the patients. And other one of the appliances, they use these wonderful titanium precision attachments that they can be located anteriorly or sometimes laterally to start in advancing the mandible, depending on what a patient needs. This one has an external lip shield that sometimes it helps to hook up the CPAP and modifying these appliances, so in case necessary. This is an example of a temporary appliance. Sometimes I use it when I don't have a lot of time with the patient and I see clinically what is going on with the patient, and the patient is not completely sure if he has it. He probably doesn't have a lot of the money to do a full examination, a full sleep study, a polysomnography, but we need to see if that patient improves. These are temporary appliances that they are not made in the lab, basically are prefabricated, just put it in hot water, and you can do a slightly advancement, at least the 50% of the maximum of the patient, and see that patient has some improvement. It's a great, great idea to start seeing if this therapy will be helpful for the patient. These are examples of combination therapy where an intraoral appliance, we can basically hook them up together or glue them together to see. And, it's mostly for patients who had a very severe apnea. Does these appliances have the complications and side effects? Yes, unfortunately, like everything, they have some problems. Within those, it could be occlusal changes because these appliances, is necessary to have the mandibles are not in contact, the maxillomandibular are not in contact, the teeth all night long. So whenever the patient wakes up, it's important to educate the patient to have some massage and have some exercises who can help the occlusion to be back to normal. Otherwise, the patient may have occlusion changes and sometimes open bites. Of course, the patient is clenching and grinding sometimes while they are asleep, and then they may cause jaw pain and discomfort. And then, again, sometimes tooth pain and discomfort because appliances, sometimes they have to be very tight to be able to function properly. But they are in general minor and very well tolerated for everybody. So the take-home message for this specific lecture or small little talk with you is that until now, dentists are not medically qualified or legally permitted to diagnose sleep disorders. Okay, we have what we have to do is basically identify our patients and then talk to our colleagues, the physician, and have a multidisciplinary approach of those patients. We are able sometimes to identify them, sometimes to see if, especially if it's a very mild obstructive sleep apnea problem, to see if an intraoral device can be helpful instead of the CPAP. And is what we have to do, especially when this patient has one of these appliances. I think dentists are the best to doing follow-ups with those patients, and then, just keep in contact with the physician. It is absolutely a mandatory requirement to have a very detailed collaboration with the physician to treat those kind of patients. And again, there is different associations that can help us to treat those patients better. The American Academy of Dental and Sleep Medicine constantly is giving guidelines to know how to treat primary snoring, how to evaluate those patients better with different therapies. What are the contraindications with the one appliance versus the other? And they basically help you to understand what are how to do a periodic evaluations of these patients, and what are the several regulations to treat this important part of the population. Well, I hope this was helpful for you, and in general open your eyes to think about all these patients which are suffering from obstructive sleep apnea. This is my email. I am happy to answer any other questions. You can contact me if it's necessary, or if you want to have a deeper conversation. And it was a pleasure to be with you today. And thank you, and see you next time. Bye.